So, hello and welcome, my dear doctors. So, like every Tuesday at 6 p.m., we are here to help you with your MBBS examination. So, today's topic is neuromuscular junction. So, you can get a full question from this along with the clinical case, or sometimes they will ask you simple a short note. So, today's topic is neuromuscular junction physiology. So what is importance of understanding about the neuromuscular junction? As we know, RMP action potential. Suppose you want to pick a glass of water. So that action potential will go from your brain to spinal cord, from spinal cord to spinal nerve, and then it will transmit from nerve to muscle. And then in the muscle, there is a excitation, contraction, coupling. So how action potential is transmitting from a nerve to a muscle, it is called as neuromuscular junction transmission. Suppose, let me assume this is the end of a neuron. How you have to write in your examination. So today's purpose is how you have to write in your MBBS examination paper. This is the nerve ending, this is the muscle ending. Okay. So this we can say this is a neuron or nerve ending, and this is the skeletal muscle ending. And whatever is happening between nerve to muscle will be called as neuromuscular junction transmission. So at the terminal of the neuron, what we have exactly, these are called as synaptic vesicles. What are these called as? So you have to draw a diagram like that. It is synaptic. These are simply synaptic vesicles. Okay, and what do they have? They are having the neurotransmitter which is called as acetylcholine. They are having neurotransmitter called as acetylcholine. So these synaptic vesicles are having acetylcholine. So what happened in the transmission? Action potential in the neuron will end up in the muscle. Neuromuscular junction transmission. So whenever there is a transmission of action potential, okay, action potential is propagating at the neuron ending. Immediately, there will be opening of voltage gated calcium channel. These channels are called as voltage gated calcium channels because they are voltage gated. What do you mean by ligand gated, voltage gated, and mechanical gated? Suppose there is a door, you want to push it, and door will open. It is mechanical gated. But when some channel is opening, when there is change in the potential, it is called as voltage gated. And some channel is opening because of the ligand over there. That is called as ligand gated channel. So at the end of the muscle, the receptor which we are having is called as simply ligand gated acetylcholine receptor. So you have to draw this diagram. Ligand gated acetylcholine receptor. Okay, so there are two receptors over here. One is voltage gated channel, other is ligand gated. What is the difference? I have told you. Suppose you are going to a mall or to an airport. So as you approach the airport, automatically doors will open. Why? Because they are having sensors that are going to sense the change in the voltage. On other hand, if you are going to a metro station, if you are touching it with a ticket, okay, with the QR code or with a ticket, it will open. What is that called as? Ligand gated. So when they attach with the ligand and gate will open, it is called as ligand gated, like acetylcholine receptor, which is present at the end of muscle. So whenever action potential is coming down, where? At the end of neuron. What is action potential? You know, the fluctuation in the ion. It is called as propagation of, it is simply, it is simply propagation of the action potential, which is happening at the end of neuron. So action potential propagation is happening at the end of neuron, and your purpose is to transmit to the muscle. So how action potential from neuron will jump to the muscle? Nerve to nerve propagation, muscle to muscle propagation, but nerve to muscle, it is called as transmission. Terminologies are very important in physiology. It is called as nerve muscle transmission. For MBBS students, this topic is one of the most important topic because it have to come in your exam, either as a clinical question or as a short note or as a MCQ. So you must know the in-depth physiology of neuromuscular junction. What is that? Transmission. So please do understand, when action potential is going in a neuron, it's called as neuromuscular junction. It's called as neuromuscular junction propagation. In the muscle, again, it is called as propagation. But nerve to muscle, what is that called as? It's called as transmission, the jumping of action potential. So how this is going to happen? For that, we have synaptic vesicles, which are embedded with the acetylcholine. We are having voltage gated calcium channel. Those are going to open only when there is action potential. So as action potential dip down at the end of neuron, what will come inside now? Calcium ion. Calcium ion start coming inside. And the most important function of calcium. What is the function of calcium? You must know. Muscle contraction, nerve stabilization, exocytosis. Exocytosis can happen only by the calcium. So one of the most important function is exocytosis. Here it will be of synaptic vesicle. Here it will be causing exocytosis of synaptic vesicles. Okay. So this synaptic vesicle will be exocytosed like that. Okay. But before this exocytosis, there's a phenomena important for your short note, docking phenomena. So what is docking phenomena? You know, dock are at the seashore. So when if you go to seashore, you will see there are docks where the cargo ships are deloading their cargo. So like that, this synaptic vesicle is like a cargo ship. It has to deload the content. For that, some proteins are present at the synaptic vesicle, other are present at the nerve terminal. When they are present at the synaptic vesicle, it is called as synaptobrevin. They are called as simply synaptobrevin. The proteins which are present at the vesicle terminal are called as synaptobrevin, and the protein which is present at the nerve terminal will be called as syntaxin protein. Syntaxin. So synaptobrevin and syntaxin, they are helping in the docking phenomena. So docking means that vesicle have to come at the end of nerve terminal and neurotransmitters will be released out to work. Okay. So after the docking phenomena, what are going to come outside? They are simply acetylcholine. What are these? These are simply acetylcholine, and these are ligand gated acetylcholine receptor. So as these acetylcholine attaches these receptor, there will be opening of the channel. Where? At the muscle. So there is going to be opening of ligand gated channel, and automatically sodium start coming inside. Sodium is more in the ECF. Sodium will come inside, potassium will go outside. And because of the more incoming of the sodium cation, this will generate excitatory post-synaptic potential. This will generate excitatory post-synaptic potential. If you remember, it is a type of local potential. Okay. And when there is a quantum release of acetylcholine, after a quantum release, these keep on adding together until they become simply action potential. So they will add together to become action potential. So this is the phenomena of neuromuscular junction transmission. But what is going to happen to this acetylcholine after function is over? What is going to happen to this acetylcholine after function is over? Answer is that if it would have been attached to the receptor always, it keeps on exciting the receptor. It keeps on causing a contraction. So that can convert into tetanus. So it should stop after a certain time. So for that, we have an enzyme called as acetylcholine esterase, which will degrade acetylcholine, which is going to degrade acetylcholine after function is over. So like that, this will be completed. So step number one, let me discuss step number one. So who is going to tell me step number one? Step number one was propagation of action potential. Sometimes they will ask you simply in the form of MCQs. What are the sequence of neuromuscular junction transmission? Step number one will be propagation of action potential. Step number two, opening of voltage gated calcium channel. Okay. Step number three, docking phenomena. Step number four, exocytosis of synaptic vesicle. Step number five, attachment of acetylcholine to ligand gated acetylcholine channel. Step number six will be generation of excitatory post synaptic potential. And step number seven will be generation of action potential. Step number eight, the final one is that acetylcholine esterase will degrade acetylcholine so that it should stop. It is a very simple neuromuscular junction transmission. Now, what are the clinical cases that can be asked from this? There are two types of cases. Number one is number one case is based on myasthenia gravis. One question can be asked from simply what is myasthenia gravis and how it is related to the neuromuscular junction transmission. One is myasthenia gravis and other will be Lambert-Eaton syndrome. Other is going to be Lambert-Eaton syndrome. So how they will ask in the examination, they will give you a clinical case. A patient is coming to your OPD and he is complaining about the muscle weakness. But when you are asking about the pattern of muscle weakness, he will say in the morning I am okay. In the morning I am strong, I don't feel weakness. But as day progresses, I start feeling weak. So at the time of night, I am very weak. What is the diagnosis? It is myasthenia gravis. On the other hand, if he is giving history of that I am having muscle weakness, but in the morning I am weak. But as day progresses, okay, I start feeling better and better. What is the diagnosis? Lambert-Eaton syndrome. Both these clinical conditions are based on your neuromuscular junction transmission. If you understand the basic physiology, only then you can make the diagnosis. So myasthenia gravis is due to antibody against against acetylcholine receptor. Acetylcholine receptor. And Lambert-Eaton syndrome is due to antibody again, but now these are against voltage gated calcium channel. These are against voltage gated calcium channel. It's very simple. Now look into the diagram. So when I was talking about myasthenia gravis, it was due to antibody against which channel? ligand gated acetylcholine channel. So if antibodies are damaging ligand gated acetylcholine channel, that will be myasthenia gravis. But if antibodies are damaging voltage gated calcium channel, that will be simply Lambert-Eaton syndrome. So number one point. So you can say myasthenia gravis is a post synaptic disorder. Post synaptic, after the synapse. Lambert-Eaton is presynaptic disorder. Okay, myasthenia gravis patient, their morning are good. Remember like that. M for myasthenia, M for morning. They have good morning. Morning are good. I mean to say they are not weak. But as day progresses, by the time evening or night, they start feeling weakness. So weakness will progress as the day will progress. On the other hand, Lambert-Eaton syndrome, they will be they will feel weak in the morning. They will feel how to differentiate in the exam between these two diseases. Is it a myasthenia gravis or is it a Lambert-Eaton? Answer is just ask the progression of the disease. Weak, they will feel weak in the morning, but as they will progress by night, they will be okay. They are stronger enough. Okay. Why? Let me tell you. Suppose someone is having 1,000 receptor. Someone has 1,000 acetylcholine receptor. And because of antibodies, 100 are not working properly. But even now, they have 900 receptors. Even now they will have, isn't it? So suppose they wake up in the morning. They are doing brushing of the teeth and then they will take bath. So they keep on utilizing the receptor. They will go to gym, they will do exercise, and they keep on utilizing the receptor. And by the time it will become evening, all receptors will be utilized and they start feeling weak. They start feeling weaker and weaker. On the other hand, in Lambert-Eaton syndrome, when antibody are against calcium channel, in the morning they are weak. But suppose they are doing brushing, one calcium will come. Okay, they are doing gym, more and more calcium will be released. So by the time they will progress, they have more calcium accumulated, so they become okay. So like that, please understand, this is very important point, how in the exam you need to differentiate between myasthenia gravis and Lambert-Eaton syndrome. So myasthenia gravis is due to antibody against acetylcholine receptor. Lambert-Eaton is antibody against voltage gated calcium channel. It is voltage gated calcium channel. Okay. Now, what is the treatment of choice in myasthenia gravis? You must be knowing that acetylcholine esterase are degrading acetylcholine after the function is over, isn't it? So, if you give acetylcholinesterase inhibitor, acetylcholine will be available for longer time. So, the drug of choice is going to be acetylcholinesterase. It is going to be acetylcholinesterase inhibitor. So, the main drugs are inhibiting the enzyme which is degrading the acetylcholine. Okay, so like that, drug of choice can be acetylcholinesterase inhibitor. So this is how you will differentiate in the exam between myasthenia gravis and Lambert-Eaton syndrome. One more thing can be asked about the botulinum toxicum. How Botox act? Nowadays we are using Botox to remove the wrinkles and all the nasolabial fold and all. How? Because Botox inhibit synaptobrin. The docking phenomena is inhibited. So because of that, calcium will not be released, acetylcholine will not be released, and muscle will not contract. So you are relaxing the muscles. So whenever we are having wrinkles and all, so whenever there are plenty of wrinkles, Botox injections are used to remove those wrinkles. On the other hand, there is a disease called as achalasia cardia, where there is a constriction of the part of the GIT. So that can also be treated by giving the injection of botulinum toxicum. Is this clear? So this is about neuromuscular junction transmission. Now, once action potential reaches the muscle, how it is acting in the muscle to cause contraction. What is that called as? That is called as excitation, contraction, coupling. That is called as excitation, excitation, contraction, coupling. Okay. So how are they working actually? The sarcolemma are invaginated inside the muscle like this. And these are called as simply T tubules. Okay. So there are invagination of sarcolemma everywhere and they are simply called as T tubules. So that action potential can go deeper. Then there is sarcoplasmic reticulum. Okay. So inside the muscle, there is invagination of the sarcolemma called as T tubules, and there are plenty of sarcoplasmic reticulum. Why? To hold calcium. To hold calcium like this. They are simply holding the calcium. And this holding of calcium is by a protein called as calsequestrin. Calsequestrin. Remember, there is cal binding, cal sequestrin, cal modeling. There are plenty of calcium proteins needed to be remembered for an exam. So, if they ask you in the examination, calcium is binding to the reticulum inside it with the presence of answer will be cal sequestrin. Now, there are two receptors. One receptor is present on the T tubule, other is present on the reticulum. What are they called as? The one which is present on T tubule is called as DHPR, D dihydropyridine receptor. And the one which is present on the reticulum is called as ryanidine ryanidine receptor. Okay. So one is called as dihydropyridine receptor. The name is based on the drug. Actually, there is a drug which is given in anti-arrhythmia called as dihydropyridine that can block this channel. So on that, it is called as dihydropyridine receptor. And there is a plant extract, ryanidine, that can block this, so called as ryanidine receptor. So just now I have told you that action potential, you want to pick a glass of water. So action potential will go from your brain to spinal cord to the nerve. Okay, till nerve it is propagation. From nerve to muscle, neuromuscular junction transmission. Inside the muscle, how they will cause muscle contraction. So inside the muscle, there is invagination of sarcolemma, and that invagination is simply called as T tubules. It is very simple to understand. They are simply called as T transverse tubules. On the other hand, each T tubules are surrounded by two sarcoplasmic reticulum and they are filled with calcium. And these calcium are stored inside the reticulum with the help of a protein called as calsequestrin. Okay. Now there is one more channel over here so that calcium can come out for contraction, and one more channel over there so that calcium can go inside for relaxation. It is called as sarcoplasmic endoplasmic reticulum calcium ATPase. So they can ask you a separate question of excitation, contraction, coupling, or they can ask you a big question, a long question, in which they will ask you how a nerve propagation will cause a neuromuscular junction transmission and how this is going to affect your muscle contraction. Okay, so whenever action potentials are going deeper inside the T tubules, they are going to excite both the receptor dihydropyridine and ryanidine receptor. So DHP receptor and ryanidine receptor, there is a mechanical configuration change. There is a mechanical configuration change that will cause release of calcium. Release of calcium. And this calcium can cause muscle contraction. The calcium which is needed for muscle contraction will be now available so that calcium can bind with the troponin C. There's a whole story I will discuss in some other chapter. So this is how calcium will be released. So release of calcium is an active process. So contraction is the active process. Release of calcium is an active process. So contraction is also an active process. What about relaxation? I have seen that most of the students are saying, sir, relaxation is a passive process. Contraction is active, relaxation passive. No, no, my dear students, relaxation is also an active process. Relaxation is also an active process. Why? Because calcium is going inside by a pump, and that pump is called as sarcoplasmic endoplasmic reticulum calcium ATPase. So don't think that relaxation is a passive process. Both are active process. So this is how excitation contraction coupling act. First of all, action potential will go deeper inside the T tubules. Okay, and there it is going to stimulate DHP receptor, dihydropyridine receptor, and there will be a mechanical. Which type of talking is going on? Physical or chemical? They are physically in connection with each other. DHPR and ranitidine will talk physically so that calcium will be released, and this calcium will cause muscle contraction. After the contraction is over, calcium will go inside, causing the relaxation. So this is how point of stimulus will be there, latent phase, contraction and relaxation. It is called as contraction phase. It is called as relaxation phase. Okay. So both are active process. So this was about neuromuscular junction transmission and excitation contraction coupling, along with the clinical concept, how to diagnose a case of myasthenia gravis and Lambert-Eaton, and how to differentiate between these two cases. So they can ask you simple as a clinical case. They will give you clinical condition. Then they will ask you diagnosis. Then they will ask you to draw a diagram. Okay. Or they can ask you a short note about the NM junction transmission, or they can ask you about the excitation contraction coupling. So this is it for today. Next Tuesday, I will be back again with one more topic. Till then, all the best. Bye bye. Take care.